Thank you, everybody, for joining today. I already see we have people joining from a few continents, so it's great to have all of you here. And welcome to our webinar on building digital solutions to advance frontline research. I am Gabriela Studemeyer. I'm a director of strategy and partnerships at Dimagi. And Dimagi, as you may already know, is a social enterprise that makes technology for social impact. And I am joined here today by three wonderful speakers who I will introduce you to now. First up, we have Amanda Gupta, who keeps herself very busy as both a research associate at the Yale School of Public Health, as well as a doctor's candidate at Johns Hopkins Bloomberg School of Public Health. And Amanda will be sharing her insights today on her research on tuberculosis and contact tracing in Uganda. So thank you, Amanda, for being here today. And next we have Elodie Lebas from the University of California, San Francisco. Elodie is the Deputy Director of International Programs and will be sharing her insights on her research on amotricin on child mortality in Niger. And finally, we have Devendra Moore, who is our Senior Director of Product. He is my colleague here at Dimagi, and he is a master at all things CommCare and the best ways to build digital solutions. So that is a wrap for our speakers. And next, I wanted to turn to the real subject of today's topic, and that is research. Research is key to everything we do. It's essential for discovering, exploring, improving ideas that can evolve from mere ideas to programs that benefit people around the world. And so as Dimagi is entering our 20th year as a social enterprise, and as we're celebrating 20 years of impact, we also really wanted to celebrate research and the key role it's played, not just in our past and our journey, but more broadly and more importantly, the key role that research plays in improving global health and development outcomes around the world. So today we wanted to host this webinar. It's our first webinar on research specifically to acknowledge the work that researchers do and also to play our role in hopefully contributing a little bit through knowledge generation and some ideas that you and the rest of the audience can maybe take with you when you go and conduct your own work. And I will conclude at that. And Amanda, I will give you the stage. I'll stop sharing my slides now. So thank you, Amanda.
Yeah, thank you so much. All right, so today I'm going to talk about kind of our challenges and the advice we would give to future researchers after implementing an mHealth intervention in a resource-constrained setting. So this is based on some work that we did a few years ago, as mentioned, from Uganda. Oh, there we go. So just as a little bit of background, which I'm sure most of you already know, but mHealth has really been exploding in low and middle income countries. And what it means to have mHealth means something different to everyone. There's a ton of different intervention types, but one of the common things is that there's really mixed effectiveness of these interventions when deployed in low and middle income countries. And so along with that, there's also very little research on implementation and technology-specific challenges that are introduced in these settings. And so really our study, what we were aiming to do was to describe the process of implementing an mHealth project, as well as then classifying key challenges to that implementation, and then proposing setting appropriate solutions to any challenges that we identified. So just as a little bit of context, Uganda is a country in East Africa with around 44 million people. They have a really high burden of tuberculosis. They have an incidence of it of around 200 per 100,000, which makes it one of the high burden countries in the world. And the Uganda Ministry of Health suggests the use of contact investigation to target high-risk individuals for TB. But the problem is that only about 20% of those that are needing TB evaluation who are identified through contact investigation end up completing TB evaluation. So kind of what's the issue here? We ran some focus groups and surveys and things like that, and really realized that there's a lot of burden placed on patients. And the main reason for that is that contacts have to go back to the clinic over and over and over again. They have to go to get their initial samples. They have to go to get test results, all that sort of things. Then another issue is that the community health workers haven't really been supported very well. They're not formally trained health workers, and then they're not really given a lot of feedback on their performance or support to carry out this work. And then finally, there's a problem that I think a lot of low and middle income countries struggle with, which is the identification of patients and contacts and keeping kind of that thread no matter where they're at in the health system and keeping the patients identified. So Uganda uses paper-based registers. That's in 2022, that's now starting to change a little bit, but still pretty much true to this day. And so that really means that people can fall through the cracks quite easily because there's not that connection. So we decided based on those kind of barriers that we would try to develop an mHealth intervention to kind of address these things. And so we utilized a customized survey application, and spoiler alert, we used CommCare. And what we did was we included decision support for our community health workers to try to fill that gap of not having a lot of support and not a lot of formal training. And then we integrated fingerprinting in order to facilitate the identification of patients. And then kind of the big piece that we were hoping to have a really large impact was the use of automated text messaging of TB evaluation results. So we were hoping to decrease the need for clinic visits of contacts. So this is kind of our overarching mHealth implementation. We created the application back in 2015, and then we went through a very extensive quality assurance procedure. We, tried to find every way we could to break the application basically before we actually launched it in July of 2016 for a randomized control trial. Throughout the trial, we did biweekly supervisory visits. And then after the trial ended, we kind of did this challenge classification to see where we did well with our implementation and where we could have done a bit better. So in order to identify kind of the challenges, we used a variety of data sources, particularly those quality assurance records from our extensive testing throughout, site visit reports, project management reports, and then throughout the entire, from 2015 all the way through the post-challenge classification, we had weekly conference calls, and so we utilized the minutes from those calls as well. And then what we wanted to do was use a framework that would help us to classify the challenges a little bit more and make them a little bit more generalizable to people that are not working very specifically in TB in contact investigation. So we utilize the Consolidated Framework for Implementation Research, which is also called CFIR. So for those of you not familiar with CFIR, this is the basic framework. I won't go too in depth with it here, but just basically you have kind of these 5 overarching domains, and then they have individual constructs within each one. So for the purposes of this study, we focused on kind of those highlighted purple areas that I'll get into in a minute, because we had published several manuscripts on the process related outcomes separately. And then the outer setting, unfortunately, we didn't really have the ability to make a lot of comments on that one based on the data that we had. Okay, so what did we identify as being our main challenges? So the first one is kind of underneath that, characteristics of the intervention construct. And really the problem was the adaptability and complexity. So adaptability and complexity here are focused kind of on the implementation. So adaptability was a little limited for us because of particular things that we had done, specifically the fingerprinting. So the fingerprinting had very specific software and hardware requirements. And because of that, they had to be sourced. A lot of stuff had to be sourced from the United States. So the actual fingerprint scanners and the cables for those scanners and the tablets that were going to be needed in order to run the fingerprinting all had to be sourced from the United States instead of being locally available in Uganda. This obviously created some implementation complexity because anytime something broke, we had to put me on a plane and I had to bring it to Uganda, which obviously adds quite a bit of complexity to our implementation itself. Then we kind of have the characteristics of the individuals, and in particular, surrounding their knowledge and beliefs about the intervention. And so for us, our implementers were the community health workers. And initially, they had a ton of enthusiasm surrounding the idea of utilizing mHealth. And the problem was there was a decline in trust with the technology over time because things wouldn't go well. And so they would find loopholes. So what I mean by that is, for example, the fingerprint scanning, oftentimes it just wouldn't work. Maybe because a cable was broken or the tablet connection wasn't quite right. And so community health workers would find ways to avoid that part of the intervention in order to continue doing their work. So that trust over time was really a problem. So even if we found a solution and implemented a new solution where the technology was working perfectly, community health workers would still utilize the loopholes that they had found when an aspect of the technology was not working. For intersetting goals and feedback, this in particular is not necessarily goals and feedback about, say, your health outcome, but rather goals and feedback about how the implementation itself is going. And so we have identified a couple challenges here, which primarily was the data processing burden. So we had really complex data. And what I mean by that is the way that we had set up our CommCare application, I had to export, I think it was around 12 or 15 individual Excel sheets in order to see one patient's progression through the health system. And so that required some relatively advanced software programs such as Stata or SAS in order to process that data and in order to give feedback on what was or wasn't going well with the actual implementation of the intervention. That complexity resulted in several months delay in getting feedback from when somebody implemented the intervention and when I could actually give them accurate data on how they were doing and how they were performing in terms of the implementation. So that really created a challenge. So that's kind of the depressing side of those were the challenges with our implementation, but what do we suggest as solutions to fix it? So really with adaptability and complexity, the biggest thing that I think we learned and what we would suggest is assessing the local environment and local hardware before you ever try to implement a solution. Along with this, assessing the local IT capabilities to reduce the amount of external help that you need. I think that a lot of people get very gung-ho about some really big new fun technologies that are being utilized in high resource settings, but really simple things might actually be more effective if you can implement them well in a resource constrained setting. And so simplifying your technology, simplifying your implementation processes can really help to create a successful mHealth intervention. In terms of knowledge and beliefs, I think we all know and recognize that first impressions matter. And so making sure that you don't roll out your application or your technology until you're sure that it's, I would say, at least 90% of the way there, that there's very few bugs. And if there are errors in your technology, make sure that you have a very timely error resolution. So simplifying that implementation process. So if somebody identifies, hey, my text messages aren't working, you can get them a solution very quickly, as opposed to having to wait a long time. This will help you maintain trust with the end users, but also it can help empower your end users to give continuous feedback and feel like they really do have a piece and a part to play in successfully implementing this, whatever your intervention might be. So with goals and feedback, I think that choosing your software is really important. I know that we obviously chose CommCare, and actually we continue to use CommCare, but utilizing that software and choosing a software that not only the end users like, but that you will actually be able to do something with your data. So after kind of our complex data structures that we had before, we actually worked with the team at Damagi to figure out, hey, how can we simplify this? How can we make this better? And now our data processing is infinitely easier, and we're able to provide feedback on a weekly basis as opposed to a monthly or bi-monthly basis. Additionally, allowing your local team and simplifying the technology enough where your local team can actually utilize your data and provide feedback coming from your local team itself. So my study coordinator in Uganda is able to provide a lot of feedback without me having to have any sort of input or say, because she's able to now work with the data in such a way that she can provide that feedback on how the implementation is going to our community health workers and health facilities. And then also, just as a note for any developers in the room, I think I just want to emphasize making sure that you're not just thinking about what the end user sees, but also what data is going to come out and what it's going to look like on the back end, because complex data structures make it really hard to know whether or not your implementation of your intervention is going well. You need good data to be able to truly understand what's going on there. And so just emphasizing the need for both really ease of use on the front end as well as on the back end. So our study did have some strengths and limitations. You know, like I mentioned, we weren't really able to provide a lot of insights on the scalability of our intervention because of kind of our lack of Ministry of Health for this particular project. We also, as I mentioned, used just CommCare for this, so it might limit the generalizability, but we, based on some conversations we've had with other implementers, we think these are pretty salient challenges and solutions. And then, as always, there's a constant shift in technologies, so some newer technologies might not face these issues. Unfortunately, we still think a lot of these issues exist, but yeah. And then, so just kind of as a wrap up for this study, I think I just want to emphasize that mHealth has a ton of potential, but we really need as a field to focus more on implementation related issues, because I think a lot of people give up on interventions that could be really successful because they don't see it being effective. But in reality, they probably just have an implementation challenge or an implementation issue. And so I think we need to utilize implementation frameworks to really better understand what's going on when we either successfully or not so successfully implement an mHealth intervention in a resource constrained setting. So just as a brief plug for like what our group's doing as our next steps and kind of how we applied these solutions is we've scaled back the mHealth a lot. As I mentioned, we worked with Damagi to simplify our data. We've focused on the parts that worked, such as the decision support tools. And we really redesigned the entire application based on our community health worker feedback to make it work for them. And the way that we did that was we really used human-centered design. And we did that to kind of redesign the application as well as to create a new implementation strategy that we are now testing in Uganda. And so, yeah, just briefly, as a thanks to our many collaborators, I just want to give a shout out to Luke Davis here at Yale School of Public Health, as well as to Achilles Katamba, who's our fantastic principal investigator in Uganda, and many others as well. So I think we're going to do questions at the end, but thank you all so much.
That was great, Amanda. Thank you. And next, we're going to hear from Elodie. Elodie, thanks.
Hi, everyone. Thank you for joining today. I'm going to talk about the Avenir study. It's a study I work on with my colleague at the University of California in San Francisco, but also my colleagues in Niger at the Ministry of Health. Okay, so a little bit of background about the study and how we came up with the idea of the Avenir study. It all started with a MORDOR study that was done in 3 countries, Malawi, Tanzania, and Niger from 2014 to 2017. In this trial, approximately 1,500 communities were randomized, and all children aged 1 to 59 months living in these communities would receive biannual azithromycin or biannual placebo. So every 6 months, we would go back and we would treat, we would census, and we would update vital status on all of these children. And the primary outcome of this study was to compare mortality between these two arms after 2 years of treatment. So now we were very excited about the primary result of the MORTAR study because it showed a decreased mortality of approximately 13% in the arm receiving biannual azithromycin. And as you can see in the graph, so each color on the right of the line represents a country. And as you can see, the Niger site actually brought the result up. It was more important there, and the mortality difference went down approximately by 18% in this country. We also looked at the efficacy of the distribution by age groups, and we noticed that in all 3 countries, the younger children would benefit the most of the intervention, with a decreased mortality of approximately 25%. So following the MORTAR trial, the WHO issued a guideline for distribution of azithromycin to reduce childhood mortality. In these guidelines, they do not recommend universal implementation, but they do recommend it in countries where you have high mortality, and on children age 1 to 11 months old, and with continuous monitoring of the efficacy of the distribution and antibiotic resistance. So using all these guidelines, we created the Avenir study design. So the Avenir study has 3 main objectives, and it's to determine the optimal age group to treat, and it's to assess for antimicrobial resistance using a different strategy for treating, and to demonstrate large-scale implementation. So the large-scale implementation is something we really care about, like leaving the research setting to go into more like a program setting. So on this trial, like it's still ongoing, obviously, but we will be working in 6,000 communities in Niger, and they are all divided in 3 different studies: the mortality study, the delivery study, and the programmatic study. So the first one and the biggest one is the mortality study, and it's a cluster randomized adaptive trial. And in this study, we will enroll like almost 3,400 communities, and they will be divided in 3 arms. The first arm, we will treat like all children 1 to 11 months with azithromycin, and children 12 to 59 months will receive placebo. In the second arm, we treat everyone with azithro, and in the third arm, we treat everyone with placebo. So this will allow us to determine like the best age group to treat. So we do in all of this community, we do the same as we did in MORTAR, which is like biannual door-to-door census, treatment, and we'll update vital status on all children, and we'll compare mortality between arms. We'll also monitor antimicrobial resistance in a subset of communities at baseline and at the last round of distribution. And we'll collect biological sample, and we will compare antimicrobial resistance between arms. So that's the biggest study, and that's the one we use CommCare Grant. The delivery trial is our smallest trial. In this trial, we just randomized communities to receive biannual azithro, no placebo, by fixed point distribution or door-to-door distribution. And we compare treatment coverage and cost to decide which method is the best to distribute treatment in a programmatic setting. So in this trial, we hire community health workers to distribute treatment, but the supervision is still performed by our study team. So now the programmatic trial will enroll approximately 2,500 communities. And in this trial, we try to integrate existing Ministry of Health system and try to move from 100% research settings to programmatic distribution. Communities will be randomized to receive biannual 1 to 11 months azithro or usual care. And usual care includes all other health-related intervention by the Ministry of Health. And it's no placebo distribution in this arm will be done. So it's just azithro in one arm and nothing in the other arm. And in this trial, we use community health worker to do distribution. So, and supervision of study activity will be done by the Ministry of Health. So it's really moving out of the research setting, going to more programmatic setting and using what's available to us to do our intervention. Our study team will still have some responsibility in monitoring efficacy by performing birth history in a subset of community to monitor mortality. And we're gonna look at the number of visits in the clinic in our age group to see if it goes down, et cetera, et cetera. And the study team will also monitor antimicrobial resistance in a subset of community. So that was a lot of information. So where are we at now? This is like the whole timeline for all the studies. In blue, you have the mortality study. In orange, you have the delivery study. And in purple, you have the programmatic study. And we are right here. We are at round 3 of distribution for a delivery and mortality trial. And we are going to start enrolling in our programmatic distribution next round. So it should start in September. Each round we add new communities to make the study bigger each round. And the primary outcome will be at round 5. So after the primary outcome is available, we hope to be able to continue into only programmatic settings starting in 2023. So how do we collect data and how do we monitor data in this trial? I'm sure you all guessed it, we use CommCare. So we use it a lot in our mortality trial to monitor progress of the team on census and treatment. We also use it for supervision. We also use it to do inventory of our study supplies. We have a checklist before treatment form that we use before going into each communities. We use it for adverse event monitoring. We use it for antimicrobial resistance study activity. We use it for verbal autopsy. We really use it for every aspect of the mortality trial. We use it less for the delivery and the programmatic trial. We still use it to collect treatment data and mostly to do like inventory and adverse events, but we use it way less because of the fact we are using community health workers. It's more difficult to use an electronic data collection tool. So in the mortality trial, the data is recorded in real time in the field by our study team, and it's synced as often as possible. So every couple of days, you're able to sync data, which allows real-time monitoring. So we download the data every Monday. So the team at UCSF download the data every Monday. And we make a weekly report and we send it to the field team. So this allows them to have like a big view of like everything that's going on since the beginning of the round of distribution. They can also monitor like every day in real time in the app, but the report is very like, it's more that what they use to monitor the data. So on this weekly report, we include a lot of data on census and treatment. So summary of enrollment, characteristic of the group and children treated, the number of refusals, the adverse events that were reported. We also monitor mortality rates in real time. And it's also very useful to check the quality of the data we collect. So we can monitor like if the team created duplicates, the average time per interview per user. We can also monitor the treatment coverage for each village we go to. And we can also make like mop-up lists, like if needed, if the treatment coverage is not good enough, we can give the team like mop-up lists they need to go to, and etc. So this part is really helpful for our in-country team because it helps them direct the supervision in real time and the area needed more work. We also can monitor progress of the antimicrobial resistance activities the same way. So we send weekly reports and look at number of grabs they visited, number of samples they collected, number of refusal, and we check the same thing for the data quality. We also use it a lot for supervision of specific census workers. So we have a big team of supervisors in Niger. And each time they go to a community, they need to fill out a checklist before going to the community to make sure everything is ready to treat that community. And this includes sensitization of the community, consent, village location is checked, because we go to really remote area, and we can take GPS coordinate before going to make sure the right village assigned to the right treatment letter and stuff like that. So once everything is done, the village is ready to be treated and the team can go. Each supervisor follows his team in the field, in the village, and each census worker is supervised closely as often as possible. And the supervisor observes the census worker, record fidelity to the protocol, using the electronic data collection form, and all aspects of the protocol is being looked at, from treatment preparation to administration to syncing tablet. And if the census worker doesn't do good on any of these activities, they can be retrained. So this part is also very helpful for our supervisor, because they can provide feedback in real time to the census worker, and they can guide the supervision they need, like who census worker needs more work and when, in which area, and stuff like that. Now for the programmatic trial and the delivery trial, we are still trying to figure out how to use our electronic data collection platform at its best, but we use it to collect treatment data and supervision data mostly. Unfortunately, the electronic data collection is not done in real time. All data is recorded after the activity is done. So no weekly monitoring is done. All the monitoring that is done after activity is done. So that's the thing we need to improve way more, and that's when that's where we want to improve on data collection in real time. So what are the benefits of using CommCare as electronic data collection? We found out that it's really easy to use and manage. So our team in the field were able to get a hang of it pretty quickly, and they basically don't need us anymore to do anything, which is great. It's customizable and flexible. So you have the form, the application you really want, everything, every little thing can be customized. So it's pretty cool. Real-time data collection is also a big plus. The fact that you can actually collect data offline, obviously, is it's mandatory in this kind of setting. And the application can be built by our study team, which is great because you don't need to bring a third party to the mix. It makes things easier when you deal with an issue, and it makes everything faster. You don't need anyone else to help you. And I think that's it. And this is all the people we work with on this study, and big thanks to everyone.
Elodie, that was also great. Thank you so much for sharing that. And thank you to both of our speakers, Amanda and Elodie, today. As I said, for Amanda, I really do learn something every time I speak to you. So I hope the audience also took away some insights from today. And I think before we jump to audience Q&A, which I've seen, Amanda, you already answered several. I think Dave and I have a few questions of our own for both of our presenters. Dave, do you want to kick off with the first question, or should I go ahead?
Sure. Can you hear me?
Yeah, we can hear you.
All right. Thanks, Gabriela, and thank you, Amanda and Elodie. That was very insightful. So as I was listening to your presentation, I think one thing came up quite a bit was about the study design or the protocol that you want to implement. I would love to get your thoughts on the role of a digital tool or system in allowing you to actually enforce the design or the protocol of your desire without having to making any compromises. Especially in relation to things that are approved by the IRB and the possibilities of this is the digital tool of choice, not allowing you to actually enforce the protocol, the design that you really want to implement. Yeah, we'd love to hear some thoughts on that.
Yeah, so I think one of the things that, someone in the chat was asking about, like, if our CommCare actually was open source right now, and I had to mention that actually it's not, because of the fact that we have everything built in for the research right now. So it actually makes things really nice for us in a lot of ways for our data collection. So right now we're doing a stepwise study design, and CommCare is actually really facilitating that process, because we're able to simply show the intervention to various health facilities at a certain date. I could just, mark that it's like, oh, if they're from, the health center Wakiso, like on May 2nd, they're going to see the intervention. And that actually is way easier than so many other things that I've been involved in before. So it's like, I think utilizing technologies, especially ones like CommCare, like it's just so easy to integrate your research study design into the actual application. So even the study that I was talking about, it was a randomized control trial. And obviously I talked about kind of our learnings from the overarching mHealth implementation side of things, but we actually had integrated our randomization into CommCare itself. And, it was a randomized trial at the household level, and we were able to simply implement that. And it was, every index patient was randomized automatically by CommCare. And that made it really easy to kind of guarantee that, well, to a certain extent, guarantee that people were getting the randomization allotment that we wanted them to get, at least from a data collection standpoint. Our community health workers had some different ideas every once in a while about what they wanted to do there. But I think that utilizing mHealth technologies, especially like as an, kind of this crossover point between public health practice and actual research, is actually really nice, because I think, our current iteration of what we're doing, if it's successful, all I have to do is remove kind of those little research related tidbits, and we could turn over the application to the Uganda Ministry of Health, for example. So I think there's a lot of potential for kind of the integration of research and public health practice to kind of coexist within these technologies.
Thank you, Amanda. I have so many follow-up questions on that, but I'll let Elodie speak to a little bit about how digital tools and the tech allow you to implement your study design of choice.
Yeah, like Amanda said, it's helping a lot to have digital tools to make sure your intervention is done properly. For example, for us, our intervention is to treat children like under 5. And so each communities gets treatment letters different for the age group, the younger and the oldest. And we use CommCare, for example, before treating each kid, we just scan the treatment bottle to make sure they receive the right letter. We have like about 20 letters, so that's a lot of letters, right? So you want to make sure they receive the right intervention, or your study is, not as good as you think it is. The other thing we use it for is to make sure like the protocol is respected. So for example, each step of the way, like for the supervision, like we make sure like the census worker that treating the kid is like doing the intervention, like preparing the treatment correctly, using the right way to treat the child. We have like a really like long protocol. Everybody on this chat who has like kids under 5 understand that like it's not that easy to give treatment to kids under 5, and there is like actually some methods that work better than others and stuff like that. So and this tool allows us to actually be like make sure the census worker gets it when we go and like and supervise him. And then at the end we make a report like every week, and they have like, oh, this census worker has that many % success in this category, and then we can go back and we can like use. So that's how we use it to make sure like We don't use it like Amanda to do randomization and stuff, but we are exploring the idea for other studies. But randomization is preloaded in the app. All the information is preloaded in the app. And so each time we go back to a household, we have all the information about this household. So everything's preloaded. We scan, we make sure it's the right kid, we make sure it's the right treatment bottle, and we make sure the intervention is done properly. So that's how we use it.
Gotcha. Thank you so much. Thank you so much for sharing that. Gabriela, I have one more question, if that's okay.
Yep, of course.
Elodie and Amanda, I would love to get your thoughts on, how you think about data security, or more generally, how do frontline researchers think about data security, and how do digital tools for frontline data collection, play a role in fulfilling the security requirements of IRB or the university or the funders?
Yeah, so I think one thing is it definitely simplifies our data management because we don't have to worry about how are we going to store thousands of paper-based forms. That's a big plus. I think what's interesting is the different requirements that exist, say, in the United States compared to requirements that exist in Uganda. So finding that balance. So in general, like our IRB at Yale will defer to, the Ugandan IRB to a certain point. But often what that means is that we're held to a higher standard in the US than what we are even in Uganda. So for example, HIPAA certification, for those of you that know and understand it in the US, is very intense, lots of patient protection and all of that. And CommCare actually is HIPAA certified. So that was even part of our initial selection, was because the IRBs, I think anytime you're working in a different country than the one that you live or work in, it can be this kind of interesting balance of how to decide what standards you're going to meet. Do you just meet whichever country has the higher standard? But then you sometimes have issues with acceptability. So for example, when we first started talking about data and feedback reports, my health workers in Uganda just wanted to send regular emails, because they were just, that's what they do in the health system there. But from an IRB perspective in the US, that is a giant no-no. You're sending unencrypted data. And so, I think trying to communicate and make sure that everyone is on the same page becomes a little bit easier when you have something like CommCare, where it's like, okay, you don't even really have to think about it because it's a certified data private, meeting all of those really high levels of protection. And I think it's just an interesting balance, I think, is how I would phrase it. And it normally ends up with several conversations with all the different IRBs, because we've even gotten the question before in Uganda of like, well, why are you doing this? That seems excessive. And it's like, well, we're doing it because, the US wants us to do it. And it is a shift, but it definitely simplifies data management because everything's in CommCare. We don't have to worry about, oh gosh, we have a ton of locked rooms or whatever. We don't have to worry about losing data. That's something, everyone always worries about when you're using paper forms, is like, well, what do you do if a piece of paper gets lost or a mouse gets into the medical record room and eats half your chart, sorts of things you just don't have to worry about.
Thank you. Thank you so much, Amanda. Elodie?
Yeah, everything Amanda said applies to us too. And it facilitates a lot. We don't have to worry about where the data is stored. Is it safe? Is it secure? Because we know your HIPAA, the CommCare is HIPAA certified. And to be honest, it's the one of two electronic data collection tools that is approved at UCSF. So it's not and we love it. I'm not saying but the choice is very limited when you're looking at HIPAA certified electronic data collection tool. So everything you said, Amanda, applies to us too. It's easy you don't have to worry about it. Someone else is doing it for you. So it's great.
Gotcha. Thank you so much. Over to you, Gabriela.
Yeah, thank you both. as you can tell at Demagi, we know that data security and privacy is important or extremely important for our partners across sectors. So it is something we take seriously. So we're happy that it has helped you at least with certain compliances. And so I have a question for both of you. You both gave great tips on your experience building digital solutions. Amanda, you mentioned user-centric design and user testing as being really important. Elodie, you mentioned data quality checks and data reports for supervisors as something that helped your team. And so I'm wondering, just on behalf of our audience, are there other things maybe you wish you'd known earlier on in a research study, or something maybe that you learned the hard way that you think our audience could benefit from? Just any more advice to conducting research?
Yeah, I think Amanda had a really good, Amanda had a really good point in her presentation that was like, make sure your app is ready, like 100% before it goes out, because once it's out, you cannot really retract. So I would say like prepare for it, like 200%, make sure like make people test it, like 10 people, 20 people test it to make sure like everything is fine, because when you are so involved in the data collection and in the app, you're always gonna think your app is perfect, and then someone else, like someone exterior at your of your organization or of your study, is gonna look at it and it's gonna be like, this doesn't make sense, and you're like, yeah, it does. So I think it's like very important that you make your app, you think it's good, and then you test it like by like other people that you do not work with, like just make sure it's like everybody can understand it, it makes sense, there is no bugs and stuff, because maybe you're so eager to go out there and to do it and to have people like start working on it that you would do it too quickly, and then you have to do like, you have to change it, you have to update version, and then for the field team, updating version on like 200 tablets is actually like, you're like, they hate you after that, so you don't want that. So do your best to like not have to do that. That would be my number one advice.
Yeah, so I think my whole presentation was kind of all the major things we learned, but I actually think I want to like kind of emphasize something as well, which is thinking about who it is that you're targeting and who's going to get left out in that conversation. So I think kind of the ethics side of mHealth, especially in resource constrained settings, is something that gets overlooked a lot of the time. So even for us, you know, before we kind of implemented this intervention where people needed to have a cell phone, we did kind of a survey of how many Ugandans actually have or have access to a cell phone, right? And we got something like well above 90% of people saying that they had access to a cell phone. However, that means that there were still people that didn't have access. And I think that's part of how we simplified things now is like, well, then all of our mHealth technology components are now in the hands of our community health workers. So literally everyone can now have access to the benefits of kind of our mHealth intervention without them having to actually own different components. Because we were quite surprised actually by how many people, when we actually started doing the trial and we actually started doing this in real life, how many people actually were like, hey, I don't have a cell phone right now. Or, well, I get a prepaid weekly cell phone. So yes, I have access to it, but my phone number changes every other week. You know, that really limits the amount of people that could access our intervention. So I think encouraging people to not only all the things I presented, all of those are massive challenges, but also thinking about kind of like the ethics of who's getting included in your intervention, but who might be getting left behind based on how you design it. Because you can still do incredible, innovative mHealth things without requiring all of your participants to have their own technology. And so I think that's just kind of our piece of advice there as well, because a lot of people were left out that didn't necessarily need to be.
Got it. Awesome. Thanks, Amanda. And Amanda, just to follow up to, I see a lot of activity on the chat. People curious about the role of fingerprinting in your work. Could you just share quickly, what the role was and what kind of workflow did it support?
Yeah, so it was primarily for patient identification. I kind of mentioned this in one of the responses to the Q&A, but in Uganda, people will tell you their name 3 different ways. And every time they come to the health facility, they'll tell you their name in a different way, just because of how kind of culturally names are. And that makes it really hard to follow patients through if you just use their name. Also, other common kind of, patient identifiers that we think of, like birthday, just a lot of people don't know their birth date in Uganda. And so because of that, you need a more unique patient identifier in order to actually follow someone through the health system. And so for something like contact investigation, you need a way to connect them to an index patient. You need a way to follow them through their lab testing results, their HIV testing results, their clinic visits, there's a lot of moving parts. And so our idea was, hey, let's use fingerprinting. Fingerprinting was probably our biggest struggle. Part of our problem was also we had partnered with a third-party fingerprinting company who was doing great work, but then about 3/4 of the way through our trial actually went out of business. So we struggled a little bit there. The developers at Damagi definitely helped us through that burden. But so that was part of our problem, I will say that. But we also just had some issues with the idea of like shifting acceptability surrounding technologies. So when we started the trial, people were gung-ho about fingerprinting, but then actually in Uganda, they started implementing fingerprinting for things like bank accounts and for things like land purchases, because everyone kind of has this problem of how do you identify a person in Uganda? And when they started doing that, patients' trust in fingerprinting dropped just steadily because they were like, no, you're going to have my fingerprint. You can get my bank account. You can get my land. And so I think it was kind of a lesson for us as well of like how just because something's acceptable when you start a project, that kind of need for that user-centered or human-centered design and it being a continual process, continual feedback of what's acceptable and what's not, because people's views of technology changes very rapidly. It can go from I trust it completely to I don't trust it at all to I'm still going to use it, all within the span of like a week. And the way that can affect your intervention is unknown sometimes, but it really speaks to the idea of you have to be pretty adaptable and pretty flexible with how you're looking at technology and how you're going to implement it. And then sometimes you just get unlucky and one of the companies you partner with goes out of business.
Gotcha.
Yeah.
Thank you. Thanks, Amanda. Elodie, one of the questions that was asked in the chat was about what did the app development team look like for your work. Could you share a little bit about like how many people were involved in the actual app building and maybe, also on the data analysis side of things, if people from Damagi were involved in the app building generally like how much time did it take to like build the first version of the app?
Yeah, so at UCSF, before starting the project, we hired a team of data analysts and they were responsible for building the app. So it was like 2 data analysts and one was 100% involved in the app developments and the other was just like helping. So it was like basically one person. And then at Damagi, you can buy lessons for your team. So we did that and everybody like took lessons on how to develop the app. And I think we did like 10 hours of like lessons and then our data analysts were like really good at it. And we needed developers at Damagi to help just like punctually. So we would like contact them once in a while, they would help us and stuff like that. It was pretty challenging at the beginning, but they got it like pretty quickly. We have like the first app was like easy to make because we just collected data, baseline data. So it was just like collecting data, but then the app for recensus where you have to preload all the data, where you have to make sure like household have like their guardians, the guardian have their kids, like all this link into the app was like very difficult to manage, but they did it pretty quickly. And then for everything that is like data analysis and stuff, the study is still ongoing, right? So we don't do any data analysis, but we just do like data monitoring. And the way we do it is we download data once a week, and then our data analyst team, so one mainly, as like makes like data report using R and send it to everybody weekly.
Gotcha.
But
Awesome.
it's
Thank you.
mostly like the data analyst team, and then on the leisure side, they just like do everything else. So it's like assigning interviews, locations, monitor that data's coming in, like everything that is data management, everyday things they do. But once a week, this piece that is once a week that is sending the report is done by our team.
Got it. Thank you. And just for everybody, the lessons that Elodie was mentioning is what we call the CommCare onboarding. It is a incredibly subsidized service that we offer, where you procure an onboarding package for like 10 hours or 20 hours, and you essentially get staffed with a CommCare coach to help you, build your own app, do your own app building, and with some guidance from our side. Because fundamentally, we believe, in building capacity, and we want to empower our partners to, to have full control on their app and ability to make changes. Great. So with that, as you all know, programs at scale today were localized interventions yesterday, and the localized interventions of yesterday were pilots. And before that, they were all research studies. So, we firmly believe that research is indispensable for improving global development outcomes. And for the last 20 years, it's been an honor for CommCare to support a wide range of use cases essential for enabling the global development community to not only generate new knowledge from research, but also to aid a swift translation of that knowledge to programs at scale. And as the Magi enters its 20th anniversary as a social enterprise, we are incredibly happy to launch the CommCare Grant for Advancing Frontline Research to celebrate universities and our research teams who've been using CommCare or other tools who share a commitment to accelerating global development outcomes. So with that, we are incredibly excited to launch our first ever CommCare Grant. Next slide, please. So as a part of the grant, the first place includes a cash award of $10,000 with a year subscription of a fully featured CommCare. You also get CommCare lessons that Elodie was referring to, the CommCare onboarding, and of course, access to our 24/7 CommCare team and opportunities to collaborate with us to promote your work. For second place, there'll be 2 recipients. Each will get $5,000 and a CommCare subscription along with a fully supported CommCare offering. And then we're also happy to offer CommCare subscriptions to 10 recipients for a year. Again, those CommCare subscriptions will be fully featured. You'll have full access to our support team and all the security capabilities that CommCare has to offer. Next slide. Yeah, to sort of summarize, the award is going to go to 13 recipients. We are offering $20,000 in financial support and a little over $200,000 in the total value that we have to offer as a part of this grant. And the deadline to apply is 1st of August. So what will happen is we'll notify you with an email with more information, along with a link to a webpage that we had created. Gabriela just dropped the link in the chat over here that will give you more information about the grant and how to apply. Our application process is very easy. It's barely 7 or 8 questions. And we really are excited about hearing from y'all. Thank you. Gabriela, any?
Yeah, just one last
words?
point that we really do love working with our research partners and value the work that they do. So we hope that this grant, which will be the first of many annual grants, helps reflect that and encourage more researchers who maybe haven't used digital tools before to make the jump. And we're always here to answer Any questions, I'll put in our email address in the chat here, but you can contact us with any questions, both about the webinar today, questions for our panelists, or about the grant. And thank you, Amanda. Thank you, Elodie. As hope I've expressed enough, we really appreciate the work you're doing and really appreciate your time and thoughts today. And thank you everybody else for joining.